Again, this is Professor Master of Nothing Teacher Tay coming to you with Chapter 19, Seizures and Syncope. Shake, rattle, roll, and ball. Alright guys, of course, look over your objectives. Makes retaining the information a lot better. Know your key terms. That'll help you along your careers. Overview of the lesson is Seizures and Syncope. Alright, a seizure is a sudden onset of random continuing electrical impulses in the brain. Kind of like the brain goes into AFib. We'll be going over these things and figuring out and defining what they are. It's a sudden and temporary alteration of the brain function caused by electrical discharge in the brain. There are typically changes in mental activity and behavior. Epilepsy is a common cause of seizure. Seizures also result from injuries or medical conditions. A convulsion is a jerky muscle contraction that is accompanied by accompanies some kinds of seizures. Some things to be thinking about. What are the consequences of a prolonged seizure? Alright, we're going to go through the pathophysiology of seizures. Primary seizures occur from a genetic or unknown cause. Generalized seizures involve both hemispheres of the brain. Partial seizures involve one hemisphere. Simple partial seizures and complex partial seizures. Seizures are thought to begin through excitation of a group of susceptible neurons in the cerebral cortex or the thalamus of the brain. These neurons begin to discharge electrical impulses which recruit other surrounding large groups of neurons. Brain cells associated with seizures are thought to occur from episodes of hypoxia, acidosis, hypothermia, hypotension, reduced blood flow to the brain. However, the most current research shows brain cell injury is associated with prolonged excessive neuron electrical discharge. Seizures are categorized as either primary or unprovoked seizures, or secondary or provoked seizures. Alright, secondary or provoked seizures, also known as reactive or symptomatic seizures. They don't result from genetic causes, but occur as a result from an insult to the body, such as a fever, infection, hypoxia, hypoglycemia, hyperglycemia, drug intoxication, drug withdrawals, eclampsia in pregnancy, degenerative brain disease, toxins, or imbalance of electrolytes in the body. So many things can cause seizures, and these are secondary or provoked seizures, meaning something caused them and it's not genetic. Alright, these are some more common causes. We just kind of went over these just now. Some more common causes. Alright. Status epilepticus. This is basically defined as a continuous seizure activity lasting longer than 30 minutes. Two or more sequential seizures without a full recovery or consciousness between seizures, meaning they had a seizure, was still postictal, and then went into another seizure. Once a seizure exceeds 5 minutes, it is likely to be prolonged. 30-minute seizure or a continuous seizure activity is in actuality the definition of status epilepticus. Some of the dangers associated is aspiration. brain cell damage from hypoxia and lack of glucose, dehydration, and fractures or dislocations. Generalized convulsive seizures, or tonic-clonic. Generalized tonic-clonic seizure usually begins with abnormal electrical activity, low in the cerebral cortex that spreads upward. It affects both cerebral hemispheres and downward, affecting the reticular activating system. We just talked about the reticular activating system in chapter 18. One of the major causes of altered mental status is an interruption in that network. Generalized non-convulsive seizures. You got absent seizures. That's when absent seizures is weird, because sometimes people don't even know these people are having seizures. They may just stare off into space for a while and get lost, may not answer you. You know, some kids have it, and their parents actually think that they're just not paying them any attention. These kids are having seizures. You got myoclonic, you got tonic, and atonic. The type of seizure actually depends on where in the brain the abnormal electrical activity begins. The level of awake and awareness that is determined by the cerebral hemisphere and the RAS involvement and other features of the seizure. Alright, generalized tonic-clonic seizure stages. An aura, some people get an aura or a feeling or a light. They may see something or hear something. It's considered a warning sign that a seizure is about to begin. Most patients that experience this, they know when a seizure is coming on because of this aura. The aura may be a sound. It could be an abnormal twitch. It can be anxiety, dizziness. It could be a smell, odor, or unpleasant feeling in their stomach. They could see things like, a light or actual, aura, so to say. They may have an odd taste in their mouth. It's different for each patient. Soon after the aura, most patients lose consciousness. The muscles begin to contract and tense up. If you've ever seen a real seizure, it can be pretty intense. They may hyperextend their backs, but either way, like I said, there are different stages. Begins with aura, loss of consciousness, the tonic phase, in which they're trembling and tensing up and doing all the shaking and stuff. Well, both phases usually last for a total of 30 to 60 seconds. Muscle spasms then alternate and relax, producing a typical violent and jerky seizure activity in the clonic phase. This is known as convulsions or the convulsive activity. The postictal phase is the recovery phase. The patient is normally altered. It may range from being completely unresponsive to just being confused and disoriented. But mental status should improve with time. A generalized tonic-clonic or a grand mal seizure is a sign of abnormal release of electrical impulses in the brain. Like we just went through the different phases. You got the aura, the loss of consciousness, the tonic phase, the clonic phase, and then the postictal phase. And this chart is just showing the patient going through the different phases here. Alright, so if the seizure stops by the time you get there, you want to provide reassurance and conduct an assessment. We'll go over assessment-based approach to seizures later on in the chapter. Follow the protocol if the patient refuses treatment, and know that status epilepticus is life-threatening. Focus on if they are still seizing when you get there, which could be status epilepticus. Focus on establishing and maintaining adequate airway, ventilation, oxygenation, and circulation. Uh, if the seizure goes on too long, it's going to cause damage to brain cells and other tissue and possibly organ failure. So you need to be real mindful of that. All right, this is going over the different types of seizures. Absence seizure. It's known as a petit mal seizure. It's common in children, but adults, it can occur in adults. They don't involve convulsions. They don't twitch and shake and all that good stuff. But instead, they just pretty much just stop communicating and just stare off into space. They normally happen pretty quickly and end pretty quickly. Maybe anywhere from 5 to 15 seconds. So, this is kind of one of those things. That's why a lot of times they get overlooked. Myoclonic seizure is sporadic brief jerks of the muscles, of muscle groups on both sides of the body. Some patients describe it as it feels like electrical shocks, like they're being shocked by electricity. If they're severe enough, the muscle jerk may cause the patient to drop an object or sometimes throw things. They can occur while they're sleeping, which would suck, to be spouse and your significant other just shoots you a bow or punches you in the face and didn't even know they was doing it. Tonic seizures is characterized by a sudden onset of greatly increased muscle tone in the body, arms, and legs, causing sudden muscular rigidity. That's the tonic phase. The clonic phase is when the muscles relax and tense back up, which causes the herky-jerky and the shaking and all that good stuff. An atonic seizure, it results in a total loss of muscle tone, resulting in a loss of muscle strength. The eyelids may droop, head nods forward, and loss of muscle strength, causing the person to suddenly drop to the ground. Atonic seizures are frequently referred to as drop attacks or drop seizures. The patient remains conscious and recovers almost immediately. I've never experienced that or known anybody diagnosed with that, but that sounds weird to just be walking down the street and just drop and get back up and go on about your business. And we see a lot in little kids is febrile seizures, which is associated with the high fever without evidence of intracranial infection. Once thought to be a sudden spike in temperature provokes these seizures. But here, current research suggests that the magnitude and the peak of the fever is more likely to cause and not the rate at which the fever develops. That's what we were taught. It wasn't how high the fever was, it was how fast the fever spiked. So I guess that's the thing with medicine and practicing. We're learning more each day with studies and stuff. So they're most common in children as young as 3 to 6 months, and even on up to 5 and 6 years old. All right, so you got simple or simple partial seizures, was once known as focal motor seizure or Jacksonian motor seizure. The patient's awake and aware of the seizure activity, but because of the reticular activating system, it's not involved, and only one cerebral hemisphere is involved. All right, simple partial seizures. You got motor seizures. The patient has the jerking and stiffening of only one part of the body and only on one side of the body. It may spread to other areas of the same side. Sensory seizures, the patient's senses may be affected by a simple partial seizure. The patient may smell or taste something, hear abnormal sounds such as ringing, clicking. They can hear somebody's voice. They can feel pain. It can be tingling, numbness. There's a variety of things that can happen depending on the patient. Your autonomic seizure, there's a change in the autonomic function of the patient's body. These signs and symptoms commonly include strange or unpleasant sensations in the stomach, head, chest, changes in the heart rate, changes in respiratory rate, or goosebumps. And then there's a psychic seizure. Signs and symptoms are changes in how the patient thinks, feels, or experiences things. The patient may present with memory disturbances, garbled speech, trouble understanding, difficulty speaking, fear, depression, happiness for no reason at all, deja vu, they feel like they've seen this before. Uh, the patient just really feels like they've been in this place before. They've done this. They remember it. It's just, so. All right. All right. This is once known as psychomotor seizures or temporal lobe seizure. Complex partial seizure usually lasts anywhere from 30 seconds to 2 minutes. It's called a partial because it only involves one cerebral hemisphere. It usually starts in a small area in the temporal lobe or the frontal lobe. Complex partial seizures may present as the patient having a behavior emergency, or you may think they're intoxicated when in fact they're actually having a seizure. To speak calmly to these people, protect them, reassure them, guide the patient gently away from objects that may be hazardous to them or even hazardous to you or others. Stay with the patient till they're completely aware of their surroundings. All right, secondary generalized seizures occur when simple partial or complex partial seizures activity spreads to both sides of the brain and involves the entire body. The seizure activity may spread from one area of the body to another and sometimes progresses to a generalized Tonic-Clonic seizure, which begins with stiffening of the muscles. Then the patient goes through those stages that we talked about earlier. It could last longer than 5 minutes. It must be treated as a status epilepticus seizure. All right. All right, we're getting into assessment-based approach. You guys should be familiar with this stuff, so I won't go too far into it. One of the things you may encounter, though, especially people that have reoccurring seizures, they may refuse treatment. As long as they come back around, they're alert and oriented, they can refuse treatment, and they may not need emergency help. So a lot of times that happens in public when they experience a seizure and bystanders call EMS. So if that happens, just follow your protocol and do what you need to do. Also, sometimes in a cardiac arrest patient, once you get them back, sometimes they have seizures due to the lack of oxygen to the brain, during their cardiac arrest event. So be mindful of that. Move furniture out of the way. Gently guide the patient away from things that can hurt them. Don't ever place anything in their mouth. Back in the days, they used to put a spoon in people's mouth having a seizure because they thought that the patient would swallow their tongue. That's a myth. We don't do that. We don't put objects in their mouth. That's more of a hazard than a help. Open the airway with jaw thrust, head tilt, chin lift maneuver. May be necessary to insert a nasopharyngeal airway to resolve persistent snoring. Keep in mind, patient's mental status is expected to improve, so they may start to gag or resist those airway adjuncts once they start to come around. During a seizure, chest wall muscles may contract, which may hinder breathing. So just keep an eye on that. Patient may appear to have an airway obstruction and may be, as long as the patient is not in status epilepticus, this should not pose a major problem. because respiration quickly returns to normal. EMT should begin positive pressure ventilation with supplemental oxygen if the patient is severely cyanotic. The seizure has lasted for longer than 5 minutes from the time of onset, or breathing does not immediately become adequate following the episode. May need to suction the patient. It all goes with clearing the airway. Transport priority circumstances. Patient remains unresponsive. Airway, breathing, and circulation is poor. Status epilepticus. History of pregnancy, diabetes, or injury. And seizure occurs in water such as a swimming pool because they could have taken water in. All right. What are some indications that a patient is having or has had a seizure? And what makes, if you determine they have, what makes them a high priority for transport? These are some of the things you need to be thinking about. Any evidence of head trauma leading to the seizure? There's no history of epilepsy or other seizure disorder. The seizure is a result of drug and alcohol withdrawal. This is our normal assessment stuff, coming down to a secondary assessment. Alright, these are some of the common medications for people that have recurring seizures. You can kind of just look over these and look them up. That way, if there's no historian on site or the patient's post-ictal or actually currently seizing, you can look through their meds and possibly see if this is a recurring thing for them. The most common recognized type of seizure is, of course, the Tonic-Clonic seizure. That's our typical seizure that we hear about or know about, and most public knowledge of what a seizure is. Signs and symptoms may include the aura, of course, loss of consciousness, convulsions, biting of the tongue, and excessive salivation. Urinary and bowel incontinence, hyperventilation and tachycardia, post-ictal confusion. Like I said again, you just want to protect your patient from injury. Position the patient. Lateral recumbent for post-ictal patients, that protects their airway in case they do vomit or something like that. Consider need for spine motion restriction if they took a fall or hit something, and maintaining the patient's airway. Use suction if need be. Begin positive pressure ventilation if needed. Maintain adequate oxygenation and transport. Just because they come out of a seizure, just keep in mind that they may have another one, so be prepared to manage that. We give benzodiazepines for seizures. We carry Versed, we carry Ativan, we carry Valium. The benzos are what we use to treat seizures in the field. And this is just going over more of the same. These are all things that we should be very familiar with. Alright, now we're getting into syncope. Alright, syncope is sudden and temporary loss of consciousness. It occurs from interruption of cerebral fusion. Common cause is increased parasympathetic influence. Bystanders may mistake syncope for a seizure. Um, uh, most syncope episodes don't last long. Patient becomes responsive almost immediately after becoming supine. What leads you to believe that it was a syncope episode and not a seizure. A lot of bystanders may confuse the two because they may do a little herky-jerky action even with a syncope episode. Skin is usually pale and moist, and most syncope episodes, the patient remembers getting faint or feeling dizzy before passing out. This is a little chart that compares seizures versus syncope episodes. So you guys kind of look over these, and so hopefully you'll be able to distinct between the two. Just go through the same steps. Conduct a primary and secondary assessment. Keep the patient supine. Consider serious underlying causes, and encourage transport. We don't just pass out for no reason. Assess the head and extremities for injuries that may have occurred in the result of muscular activity or the fall to the ground, or maybe they hit their head on a table when they passed out, or whatever the case may be. So just do a good assessment on these patients. Alright, in summary, seizures result from abnormal electrical impulses in the brain, which can manifest in a variety of ways. Seizures may be generalized or partial. Status epilepticus is a life-threatening emergency. Okay, people? Life-threatening. Syncope results from temporary interruption in the brain perfusion. Syncope may be benign, but can have serious underlying causes. Alright, thank you guys again. We'll see you on the next go round.